All right, we're going to perform, my name is Ryan Shiskin, and we're going to perform an abdominal assessment today on our lovely volunteer. Before anything, of course, before entering the room, we would knock, make our presence known. We want to take care of privacy issues and everything. Once we come in, we'd wash our hands, glove up, and we'd introduce ourselves and explain to the patient what we were going to do. Just let her know that we're going to do an abdominal assessment. Once again, for privacy, we're only going to expose the areas necessary for the assessment. And we will, for this specific assessment, we will go in the order of inspection, auscultation, percussion, and palpating, as opposed to all the other assessments where auscultating is at the end. We do this because palpating and percussing will distort the bowel sounds, and we want to make sure those are what they're supposed to be. So, first thing, like I said, we come in, we're just going to inspect first. We're going to use our eyes. We're basically looking for the contour, shape, symmetry of the abdomen in general. We're looking for any kind of distension. If there is any distension noted, we would go ahead and measure that girth with a measuring tape. Also, before we do the assessment thoroughly, we would assess whether or not the patient has had a bowel movement and needs to go to the bathroom. Basically, it's more for their comfort. We don't want to be pressing if they've got a full bladder. And also, if she is in the appropriate position where she is supine with her knees slightly flexed, takes a little pressure off the abdomen as well. So once again, like I said, we'll go back to inspecting. Shape, contour, symmetry of the abdomen. Distension, if noted, we'll measure it with a measuring tape. We're also going to take note of the umbilicus, and we're going to make sure it's midline, the shape and contour of that as well. Make sure the skin is consistent with the rest of the abdomen. We're also going to be looking for any lesions, bruising, striae, any kind of masses as well, any kind of pulsations visibly that we can note as well. Basically, just try to get as big of a picture as we can just with our eyes before we go in and start fiddling with stuff. So after we inspect, we're going to go into the auscultating phase with our stethoscope. What we're going to do is we're going to listen for bowel sounds. Normally, they're going to be between 5 and 30 per minute. Less than that would be hypo, more than that would be hyper, of course. And in order for us to say that there are no bowel sounds whatsoever, we have to listen for at least 5 minutes before we can make that distinction. And we're going to use the diaphragm of our stethoscope for that assessment. And we will go ahead and make sure it's nice and warm for the patient, for their comfort. And what we'll do is we'll start in the lower right-hand quadrant and follow the large intestine around. So we'll start in the lower right, go up, and then to the left, and then down. I think our patient is hungry. I can hear that. After we go ahead and listen for normal bowel sounds, we will go ahead and auscultate for bruits, which is like a whooshing through the arteries. And what we'll do for that is, instead of the diaphragm, we'll use the bell, because it's a different pitch sound, and the bell is more equipped for that. We'll warm that up as well. And what we'll do is we'll start at the aorta, move our way down to the renal arteries, then the iliac arteries, and then the femoral. So the aorta is slightly above the umbilicus, and then we'll go to the renals, and then the iliac. Basically make a little pentagon shape around the umbilicus, and then the femoral. Alright, and that will complete our auscultating phase. Now we'll move on to our percussion phase, and basically what we're assessing here is tone, and we're assessing for organ placement and just natural positioning of everything. Over the general abdomen, we should hear more of a timpani sound, more of a higher pitched noise, and then over the more solid organs, we should hear a duller sound. And we're going to make sure that we percuss in all 4 quadrants as well. This is usually the patient's favorite part of the assessment. All right, now that that's done, we're going to go into our palpating phase, which is our last assessment. Basically for this, what we're going to look for is we're just looking for any kind of masses again, feel any kind of pulsations. This is going to be very light palpation, not deep, only about 1 to 2 centimeters in a slight circular motion. We're going to be feeling for any kind of rebound tenderness, any tenderness in general, any signs of guarding, pain, and yeah, we'll just go ahead and go in. Just feel around. Any pain? Patient fell asleep on me. Must be doing something right, not hurting her. And yeah, also for there as well, we're palpating for any kind of distension as well that might not have been physically noticeable with in the inspection phase. We would be able to feel that then as well and do the appropriate interventions. And that would conclude our abdomen assessment. Thank you very much.